Infirmary and Training Complex from Bangladesh. So he has a lot of awards to his credit. He has won the Mubarak Ali Memorial Award and Professor M.A. Mateen Gold Medal Award, Professor Haroon Memorial Award, and the SARC Academy of Ophthalmology Achievement Award, a time frame ranging from 2012 to 2018. So he will be talking to us on his experiences on managing lens-induced glaucomas. So over to you, Dr. Shams.
Dr. Co-instructor and respected audience. Actually, it is a discussion over the glaucoma surgery and trabeculectomy mix. And within this, the lens-induced glaucoma, it's quite a different discussion among you. I'm trying to share my experience. So, no financial interest. Bangladesh has 700,000 blind people, and cataract contributes to 80% of the total blindness. Now the condition is improving within a very good healthcare program by National Eye Care Program. And what are the barriers? Actually, the same barriers is in the Indian subcontinent. The remoteness, limited healthcare facilities, and other socio-economical barriers, lack of awareness, and for this, the lens become hyper-mature and causing the lens-induced glaucoma. And the definitive treatment is the surgery, we know, but surgery faces some challenges like high intraocular pressure. You have to do the cataract surgery with a high intraocular pressure, corneal edema, bleeding, inflammation, increase the risk of expulsive hemorrhage. Hard nucleus is often associated with the dialysis. And what is the ideology of this surgery? To reduce the intraocular pressure and to improve the vision, killing two birds with a single stone. And what are the phacolytic lens-induced glaucoma? I am highlighting the phacolytic, phacomorphic, and some trauma cases. The phacolytic glaucoma, you know, some symptom like the Morganian shape and capsular calcification, sometimes the clogging materials all over the anterior chamber, and may be associated with the subluxation. Sometimes it may present with clogging materials in the corneal endothelium and also like a pseudohypopyon. And phacomorphic, shallow anterior chamber with mature or immature cataract, endothelial decompensation, swollen lens, and anterior shifting of the lens iris diaphragm. And what I am doing actually, I used to assess the patient. And if it is a very high intraocular pressure with the long sufferings, admit the patient, and it depends on the remoteness and patient's socio-economical condition. And I used to give a hyperosmotic agent, anti-inflammatory, usually steroid, sometimes systemic steroid, antibiotic, and I used to do the B scan. I don't know what is going on in the posterior chamber. And in case of phacomorphic glaucoma, I used to do the other angle evaluation. And so in case of phacolytic glaucoma, here is the intraocular surgery, is small incision cataract surgery. So we have to do a very careful CCC under guidance of the blue, and we have to think of the genular stability, cortex removal by Simcoe, inflation of the bag. I like to inflate the bag repeatedly, and nucleus removal should be with a very precautious way, and sudden decompression should be avoided. And this is another case. In that case, if you see, after a very good guidance under blue, we are doing the CCC, and I'm telling that the repeated inflation of the bag to maintain a very good CCC, to avoid the extension, and we have to think that there might be some genular weakness, or sometimes there might be some hard nucleus here, so sudden decompression should be avoided. Sometimes anterior capsular puncture can release the intralentricular pressure, thus lens iris diaphragm moves posteriorly. And this is one case where we did the phaco surgery in the lens-induced glaucoma, the same careful CCC. Genular weakness we have to be think of. And the CTR ring, if you need, you have to give the CTR ring, and you have to do the phaco surgery with a low phaco power because cornea has been decompensated already. So here the visibility is a challenge, so preoperatively hyperosmotic agent should be given. This is another case. I am telling that after doing the CCC, we have to do a very cautious phacosurgery, and sometimes we don't know what is the condition of the nucleus, where we have to take care of the endothelium. And this is another case of phacolysis with a subluxation of lens. I am doing SICS surgery. In that cases, we have to do a large CCC, and as the lens is subluxated, we have to be very much careful removing the nucleus through the anterior chamber, and then I am putting the CTR ring here. So sometimes when putting the CTR ring, we have to take care that it must not go through the vitreous, through the dialysis portion. You have to be give it within the bag. And after giving the CTR ring, the lens is introduced. And this is another case of phacolytic glaucoma after giving the hyperosmotic agent. Corneal decompensation has been improved, and after admitting the patient, we gave him frequent corticosteroid, and as lens is very much hurt here, so it was really tough to do phaco. But I did this, but I am not in favor of doing phaco surgery in such type of hurt cataract with decompensated cornea. And it is a phaco surgery in a phacolytic soft cataract. In that cases, we have to give a very low phaco power because it looks like soft. And after removing the whole nucleus in the and separate the nucleus, very low power phaco we can do, and we can remove this very easily. So some experience within my institution, and what published in 2 or 3 journals in the lens-induced glaucoma, and I did 50 patients. It is a comparison between the 25 phacolytic and phacomorphic, and immediate postoperative. What is my experience actually? Immediate postoperative visual outcome is better in the phacolytic group. After 6 months, result is almost same in terms of vision if optic nerve condition is good. Intraocular pressure moderately increased in phacomorphic group in the immediate postoperative period. Inflammation is more in the phacomorphic cases. Corneal clarity is more disturbed in the immediate postoperative period in the phacomorphic cases, and glaucomatous changes are more observed in the phacomorphic group. And what should be the surgery, SICS or phaco? Some journals suggested the small incision cataract surgery is a very good result, and some journals suggest that the phacoemulsification has the same results. So actually, we have to take decision with our own. Our final target is the vision. So it is a compromise that we have to take care of this, and expectation of the patient, expense of the patient. It depends from patient to patient. Confidence of a surgeon, efficiency of a surgeon, and you have to take care of the optic nerve health and duration of the sufferings. So all phacomorphic cases may not be phacomorphic glaucoma only. So other eye evaluation is very much important. Other eye angle evaluation is important. In the phacomorphic cases, if other eye angle is very much shallow, we have to think that it might be a case of combined mechanism glaucoma, chronic angle closure with phacomorphic attack. In that cases, I like to do that combined surgery. And during hypermature cataract, repeated inflation of the bag to make a very good CCC. during hard lens, we have to think about the zonulodialysis. So low phaco power you can use. Angle wash is mandatory. Sometimes in the phacolytic cases, we can see the lens materials in the behind the posterior capsule. So don't run after the lens materials behind the posterior capsule. It will be absorbed with time. Systemic steroid can be used.